Hello, my name is Adam Rokshan, and I am a PGY5 in orthopedic surgery at the University of Western Ontario. I have no disclosures. Today I am presenting my poster on determining the rate of reoperation and predictors of reoperation in tibiotalar arthrodesis. I'd like to thank my co-authors, Dr. Lewendy, Dr. Sanders, and Dr. McLeod for their valuable input into this project. The main objective behind this project was to determine the total reoperation rate to the ipsilateral foot, ankle, or leg after tibiotalar arthrodesis. Our secondary objectives were to determine if there were any predictors of non-unions requiring reoperation or any infections requiring reoperation. The reason to pursue this project was to fill a gap in the literature regarding the results of tibiotalar arthrodesis in the real world, i.e. in uncontrolled settings such as primary trauma, variably comorbid patients, and in the setting of other foot, ankle, and leg procedures that are commonly performed at the same time as the index procedure, among other factors. Preoperative varus alignment and previous subtalar fusion have been found to be predictors of non-union, while smoking, alcohol use, diabetes, psychiatric conditions, and illicit drug use have all shown trends towards significance for non-union. No predictors for reoperation for infection have been identified in the tibiotalar arthrodesis literature. To achieve our objectives, two reviewers went through the charts of all the primary tibiotalar arthrodeses performed between September 2012 and August 2017 by 3 fellowship-trained surgeons at a single site. Overall, 161 arthrodeses performed in 158 patients were included in our final analysis. Patients had to be at least 18 years of age and been followed until union was identified, or for a minimum of 3 months, whichever came first. A comprehensive data collection sheet was developed to obtain and codify patient demographic data, operative data, and radiographic data. Union was determined radiographically by identifying loss of at least part of the tibial and talar contours with evidence of bony trabeculae crossing the site at the domo dentalis/plafond. Delayed union was defined as no loss of contour/trabeculae crossing by 6 months post-op. A reoperation was considered to be any operation performed to the ipsilateral foot, ankle, or leg after the tibiotalar arthrodesis had been performed. We identified 14 variables that we were interested in statistically testing. These were age greater 65 or greater, male sex, BMI greater than 30, ASA score of 3 or greater, psychiatric conditions, diabetes, renal disease, cardiovascular disease, current smoker, use of a hind foot nail, previous operation to the foot or ankle, post-traumatic osteoarthritis, use of an external fixator for ankle trauma, or previous open injury to the ankle. Two-sided Fisher's exact testing was utilized to determine if there was any correlation with reoperation for non-unions or infections. This was employed because of the low number of incidents in each cohort. With regards to our results, our average follow-up time was 1.9 years. Our overall reoperation rate was 31.1%, or 50 out of 161 arthrodeses. 9.9%, or 16 reoperations were for non-union, and 7.5%, or 12 patients, had reoperations for infection. 6.2%, or 10 patients, had non-unions that did not go on to have reoperations. 8 patients had infected non-unions, which we did not consider in the non-union cohort. The remaining reasons for reoperation were distributed into 6 broad categories, including malunion, skin issues, other aspects outside of the tibiotalar arthrodesis, subtalar arthritis, hardware irritation, and chronic pain. The average time to reoperation was around 1 year. 13.7%, or 22 patients, required more than 1 reoperation to the ipsilateral foot, ankle, or leg. Ultimately, 3.7%, or 6 patients, went on to have bony amputations. With two-sided Fisher's exact testing, we identified cardiovascular disease as being significantly correlated with reoperation for non-union. Remaining testing did not find any further significant correlations between the 14 predictors and reoperation for infection. Overall, the strengths of this study are the fact that a sizable cohort was reviewed, around the second or third largest for an individual study in the current literature. We also gleaned a significant amount of information from patient records and took into account a variety of factors involved in the reoperation rate in tibiotalar arthrodesis, along with testing for the 14 predictors. The downsides to our study are that it was retrospective. Charts with missing data and incomplete past medical histories were infrequent, but could have affected the outcomes of our analysis. We also only performed 2 tailed Fisher's exact tests. This means that the correlation could have also possibly been in the opposite direction, having a protective effect against non-union or infection. Also, we tested all variables independently of one another. Cardiovascular disease, renal disease, and diabetes are not necessarily mutually exclusive. A multivariate analysis, however, might not have been helpful, given only one factor achieved a significant result. In terms of where we would like to see further research, there is surprisingly little data on how cardiovascular disease affects bone healing. basic science studies and animal models may be an option. Also, and this was the most noteworthy aspect to me after going through hundreds of x-rays, is there's very little research on determining when an arthrodesis is radiographically healed. I started to identify some patterns in the healing process and possibly some radiographic parameters that might predict early on whether a fusion will go on to unite or not. Stay tuned for more on this topic. Thank you very much for your time, and I look forward to your questions.